Just give me a second.
And there we go.
Good afternoon. Thank you for joining us. I'm Laura Brenner, and I'm the coordinator of the local immigration partnership. In case you haven't been to our website, it's lethbridgeimmigration.ca. This webinar will be posted there later. We're excited to be with our Lethbridge Newcomer Health Advisory Group, which is a working group of Lethbridge LIP. And we have a webinar for you with lots of information, which is called the Newcomer Mental Health. We're going to be talking about cultural safety and trauma. And we have some settlement workers from Lethbridge Family Services that will talk about some of their experiences and some of the issues that they see with their clients. So we're very excited to have them all. Sasha Donahue is our chair for the working group, and just going to do a little bit of housekeeping. Lindsay is part of our working group as well, and I'll introduce Dr. Bly in a second. How we're going to do this is please keep your mics off. If you have any questions, if you could please put them in the chat box. All right, I will hand it over to you, Dr. Bly.
I'm Dr. Bly. I'm a family doctor by training, but I've been working with newcomers for most of my career. And I have been with the Lethbridge Newcomer Health Advisory Group since before it was called the Lethbridge Newcomer Health Advisory Group. Our first speaker is John Thompson. John holds a bachelor's degree from the University of Lethbridge in anthropology, as well as the designation of registered social worker. He has worked in suicide prevention since 1989, first as a crisis line volunteer and a board member, and later as a rural liaison. John has been with the Outreach and Education Program since 2001, with a primary focus on suicide prevention and family violence prevention. He is an engaging public speaker and enjoys providing presentations and workshops on a wide variety of topics to individuals, groups, and organizations. John has had the opportunity to contribute to the development of the suicide intervention training, co-authored the Corrections 1154 course called Suicide Prevention in Correctional Settings, has supported the development of the Accountability for Change Family Violence Treatment Group, as well as coordinating the Community Helpers Program. He has also represented Lethbridge Family Services at local, provincial, and national conferences on suicide prevention and family violence. John has been married since 1998 and is a stepfather of 2 and a grandfather of 1. He is grateful for the opportunity to be a member of such an eclectic and exciting team. Over to you, John.
Thanks, Doctor. I realized that came right off the website. Wow, I could probably have edited that for you a bit. I'm John Thompson. I'm the Supervisor of Outreach and Education here at Lethbridge Family Services. We offer educational presentations and workshops on lots of different topics to lots of different people. And today I've been asked to do a short presentation on trauma. So I've called that one Trauma 101. And I'll follow that with a very brief introductory presentation on a more than a concept, a principle and a practice of cultural safety. So bear with me while I pull up my presentation. Okay. Now, can you see the presentation? I'm asking the committee members there.
Yep, we can see that.
So are you looking at you're not looking at my presenter view, you have the full slide, correct?
We can see presenter view right now, John.
Darn. That is so unfortunate. How about now? What do you got?
Same thing.
Gosh, okay. We went over this last time. I'm going to try this again. Okay. How about now?
Perfect.
Okay, good. Gee. Okay. So I'll get right into it. This is going to be a short presentation. Again, if you want more information about this topic or other ones, or you're interested in follow-up presentations, please let the committee know, and they can also put you in touch with me if you'd prefer. So thanks. Okay, so defining trauma. At one point, trauma was considered essentially to be the event itself. It was considered to be, the trauma was the car accident or the assault or the abuse. The understanding of the word trauma includes the effects of the event as well. So we've had some movement there, I think, in a good way. The DSM, they've included definitions of trauma that include real or actual, so actual or feared death of self or others. And then oftentimes that's looked at as really narrow, so that at one point, the only time an experience could be considered to be traumatic is if there were feared or actual death of self or others. And I think I'm glad to know that we're way past that. We've started to broaden our understanding of the effects of these events on an emotional and psychological level that's different than we did before. So trauma is the lasting emotional response that often results from living through a distressing event. We'll talk a little bit more about the sense of safety and sense of self in a little bit. And that is the definition, or at least a good chunk of it, from CAMH. So I think, again, a much broader, a much more inclusive description. As opposed to trauma, an injury, a wound, living tissue by an extrinsic agent, disordered psychic or behavioral state. So that one is right from the Merriam-Webster dictionary, so including the Greek origin of the word and so on as to wound. But now we're including, if you look at the bottom part of the slide, the psychological reaction to emotional trauma now has a name of its own. So post-traumatic stress, or in the extreme might not be the right word, but to the furthest extent, we would be talking about post-traumatic stress disorder. So myths about trauma and post-traumatic stress. There is still a myth out there that trauma and its effects last forever. This is, of course, not true, thankfully. So while many people will suffer post-traumatic stress in the aftermath of a traumatic event, few will develop full-blown post-traumatic stress disorder, the actual disorder itself. And there is, of course, support available for that. Trauma only results from life-threatening experiences. Again, we went through that a little bit in the definitions. So applying a broader definition, traumatic events are ones that change or challenge a person's core beliefs about themselves or the world. And I think that part of trauma is much more, certainly at Lethbridge Family Services in the counseling, outreach, and education program, that is much more what we mean when we talk about trauma, the lasting effects that change or challenge a person's beliefs about themselves and the world. So nothing good can ever come out of trauma. That is, of course, a myth. So the concept, or again, the lived experience often of post-traumatic growth does happen. So people find a way to not be defined by the traumatic event, and often find ways to incorporate that experience moving forward in a resilient way. So where the forward momentum becomes on growth, on making meaning, hey, building meaning of the traumatic event. There's the little credit for you that came from Psychology Today. So examples of experiences that can result in trauma: sexual assault, death of a loved one, witnessing an act of violence, domestic violence or intimate partner violence, natural disasters, severe illness or injury, adverse childhood experiences. So many of you probably familiar with the ACEs study. I want to talk about this piece a little bit more, because it really gets to the psychological and emotional impact of trauma, the changing of one's worldview or one's view of oneself. You might recognize this in a different shape. This is an adaptation of Maslow's hierarchy of needs. Only because I'm witty and clever, I put it in the pie and called it the hierarchy. Just a couple of quick things about Maslow's work. Some people know, lots of people don't, that Maslow did his field work in Alberta on reserve near a place called Gleason. And so what is often seen as a pyramid in his diagram of the hierarchy is actually a teepee. This actually comes from Indigenous philosophy and spirituality. And more than what it takes to have one's needs met, so more than just a list of, hey, to be safe, I need good locks on the door, or I need to be in a physically primarily safe environment. More than that, what we're talking about with these needs is the emotional experience that we have when they are met or not. So when our needs are met, when we feel safe in our relationships, in our house, safe within ourselves, if we think about it in a personal boundaries kind of way, safe in our relationships, we feel connected, we feel like we belong somewhere, people would miss us if we weren't there. And we feel empowered. That is, we feel able to enact change. We feel able to affect change in our daily experience. And we'll talk about that a little bit in cultural safety as well, that there is an empowerment part. There is a patient or client as participant, as affector of change. And then, of course, self-worth, or what Maslow called becoming a fully self-actualized person. But if we think of it more like self-worth. So when our needs are met, we have feelings similar to these, maybe not exactly these, but similar to these. We feel happy, content, we feel confident, worthy. But when they are not met, when our need for safety is not met, and again, that could be in a physical sense. So if someone broke into my house last night and stole some of my things, I might have the experience of feeling unsafe in my home. But even if I felt unsafe and still felt empowered, and I called the police and the police came and they caught the person and they gave me my things back, they might say, well, there you go, you're safe again. But again, we know our needs are met based on how we feel and not based on how it looks. So when we think about a traumatic event, it's all about the experience of the individual. So people can experience similar things or statistically similar things, right? Like, let's say a car accident or something like that. We could experience a car accident even with other people in the same car, and our experience of that is different. Our emotional experience of that is different, right? It's not as though all of us would have the same response to that trauma. So when our needs aren't met, we often have feeling experiences like these, feeling sad and empty and lonely and depressed and angry and hopeless and helpless and worthless. And we know that we're in trouble. We know that we're in an emotional crisis, that things are really difficult if we have the emotional experience of feeling as though all of our needs are unmet all at once. So what can trauma look like physically, emotionally, psychologically, spiritually? I didn't put that down there to think that we could make an exhaustive list in a couple of minutes of a presentation. But I want you to think about it in that context. And again, you might recognize those 4 components as a representation with respect of the medicine wheel, again, from Indigenous philosophy and spirituality and ways of knowing. So we can recognize that when we are affected by trauma, we are affected in every sense, right? In every portion of who we are. So recognizing resistance and growth. Sometimes, again, this is a demonstration of the movement beyond trauma being something that we are passive receptors of, that things happen to us. Because we need to also recognize resistance. So even in the case of abuse or other adverse childhood experiences, there is resistance, sometimes subtle, but it's there and it counts. And the resilience afterwards, the bouncing forward, if you will, instead of just bouncing back from something, comes from the meaning making part, right? That we can get to a place where we can start to understand the experience in a different way. So any of you that have been through a powerful experience for you, I won't say necessarily traumatic, because I certainly couldn't diagnose that, but for some of you, they might be traumatic events, but certainly powerful events. Any of you that have come through powerful events in your own life and who have said, if I can help one person based on my own experience, then it's worth it. That bouncing forward, that resilience of yours to make meaning out of that experience, to be able to offer support to other people who maybe are now where you once were, is an illustration of that resistance and growth and post-traumatic growth. I pretty much told you what was in this slide, so I'm not going to read it to you. I'll leave it up there for a little bit so that when the recording is up, if you want to watch that and pause and read through it, you certainly can. Okay. A post-traumatic growth inventory. So looking at when we've gone through a traumatic event, the preparation for growth, the preparation for making meaning comes from an appreciation of life, relationships with others, fulfilling connections, right? New possibilities. So again, you might think of that almost as like the future focus kind of idea, right? Looking toward tomorrow. An emphasis on personal strength, okay? And of course, the spiritual part. That is perhaps the quickest presentation I have ever done on trauma, and I'm still 4 minutes over where I should be at the end of the second presentation. Help me, committee. What do you need? Where are we at?
I think you're good to go, John, with
Okay.
the diverse or the cultural competency.
Okay. So I'm going to go new share. In fact, hold on. I'm going to make sure that I'm out of there. I'm going to make sure that I'm out of there. Oh boy. New share. Now, by my calculations, you can't see anything.
We see your PowerPoint frames and the platform.
Okay, but you can't see the Okay, I'm going to do it this way. Theory number 2. That is so strange. Slideshow from the beginning. How about now?
It's the two
You're in
cards again.
presenter view.
Okay, I'm going to hide presenter view
Looks
and
good.
minimize that.
Oh,
Uh,
that's still,
Okay,
yeah.
I can't minimize that then. Let's see.
If you start your presentation, won't it leave presentation view there?
Okay,
There.
are we good?
We still see your slides on the side, but
That is so odd. That is really odd because that tells me that we're going through presenter view, but I'm going to roll with it because I need to. Yeah. Okay. So cultural safety. That means you can probably see that too. Here it is. Cultural safety had its beginning as a construct, as a way of viewing cultural influence in the 1980s, driven by the experience of Maori, essentially medical students, and then was expanded to include the experience of Maori people in a general sense. So as a foundation to explain the poor uptake of health services by Maori people in general. Okay. So cultural safety is an approach that considers how social, historical contexts, as well as the structural and interpersonal power imbalances shape health and healthcare experiences. Practitioners are self-reflective, self-aware in regards to their position of power and the impact of this role in relation to their parents. So, or patients, I should say, sorry. And cultural safety itself, remember, is defined by the person feeling it or not, right? So in this case, safety is defined by those who receive the service and not by those providing it. So a broader definition, cultural safety is based on the understanding of power differentials. It exposes the social, political, historical context and enables practitioners to consider difficult concepts such as racism, discrimination, prejudice, and colonization has contributed and continues to contribute to health disparities faced by Indigenous people today. That's from the Aboriginal Nurses Association of Canada, 2009. I think I'm just going to have to bring up the entire slide so that maybe we're somewhat even. So cultural safety, this is a part that really drew me, that cultural safety can be defined as an outcome that is the gold standard in contemporary healthcare. It promotes a healthcare environment that is physically, spiritually, socially, and emotionally safe for clients. It requires respectful relationships, ultimately empowering clients to comment on practices and participate in achieving positive experiences and health outcomes. Cultural safety extends beyond cultural awareness, cultural sensitivity, and cultural competence. Cultural safety is not achieved until the client says it is. So again, we talked about that this is about the experience of the individual, right? It's not about, in the example I gave you in the trauma presentation of my house being broken into and the police coming and helping me and telling me that I'm safe. I'm not safe until it's a feeling experience of mine. So just looking at different pieces then, looking at cultural awareness as an attitude that includes awareness of differences between cultures. That cultural sensitivity is an attitude that recognizes the difference between cultures, and these differences are important to acknowledge in healthcare. Cultural competence is an approach that focuses on practitioners attaining skills and knowledge and attitudes to work in more effective and respectful ways with Indigenous patients and people of different cultures. Cultural humility is an approach to healthcare based on humble acknowledgement of oneself as a learner when it comes to the understanding of a person's experience, a lifelong process of learning and being self-reflective. Cultural safety, and again, this is kind of the full circle moment. It's an approach that considers how social and historical contexts such as interpersonal power imbalances have shaped healthcare and health experiences. Remember, safety is defined by the people feeling it, receiving the service, not by the people providing the service. And then, so culturally safe care then requires building trust with Indigenous patients or patients of many cultures, and recognizing the role of socioeconomic conditions, history, politics in health, and requires the communication and respect for a patient's beliefs, behaviors, values, and ensures the client or patient as a partner in decision making. So putting cultural safety into action, do something. Having good intentions isn't enough. Taking action, speaking out, noticing and saying something, as I've often said, particularly when we're working with youth. Taking responsibility as a learner, so recognizing that it's our responsibility to broaden our understanding of the people that we serve, not the other way around. Take time for self-reflection and commit to lifelong learning. I talked to Laura earlier, and she will make this this infographic available to you. I know it's really small on the screen at the moment, but she'll make that available to you, and it's again, a foundational thing, but it's a one-pager, and it'll give you some resources to look at if you want to learn more. Thanks, everybody. Super brief, but there we go.
Thank you, John. All right. So moving on, our next speaker is Tribikram Rizal, who prefers to be called Vic for obvious reasons, and his friends back home call him Vic. He's been with the agency since 2010 and has worked in many different areas of settlement. In the past, he's been a youth settlement practitioner, assisting newcomer youth with education, employment, and youth empowerment. He is currently the acting director of Youth Settlement Services for LFS. Vic started working with families as a settlement practitioner in 2016. He's always been a people person and loves being around people. He loves meeting new people, learning about different cultures, and helping people when they need it the most. Vic loves and respects all forms of life, as we are all unique and different, and call the same planet our home. Vic believes in living each day to the fullest and is motivated to help people do good, be good, respect others, and enjoy every minute of his life to the fullest. Over to you, Vic.
Thank you so much, Dr. Bly. Thank you for everyone being here on Zoom and giving your time to listen to what we have to say. So I'm going to talk a little bit about, like Dr. Bly said, I work as a settlement practitioner, so my role is to work with a lot of new immigrants coming to the country. So I basically work with a lot of newcomers who are funded by the federal government, and I work with a lot of refugee families from all around the world that are destined to come to Lethbridge. So so for immigration, anyone that comes to this country has definitely come to this country because they have had some kind of political, economical, environmental issues in their home country. That's the reason why they have chosen to come to Canada. So they do come with a lot of stress already. So I'm going to talk a little bit about stress, pre-migration stress, post-migration stress, and a stress that happens or the kind of mental health issues they go through during the integration process. Lots of people that come here have already been fleeing conflicts. So I work with a lot of clients that have, giving an example of Syrian refugees that I work with. They have come here because they have experienced a lot of trauma and other things in the war that took place back home in Syria. I have been working with a lot of people who have fled Congo, civil war, and Eritrean political war. So whenever we receive clients, we do receive a whole package. It's not only clients, they come with the twin stress and anxiety and lots of PTSD and a lot of mental health issues. We see a lot of that with some of the clients that we have been working. One of the clients that I can never forget is a lady that I was assigned to work with who fled a civil war in Congo, but she was a survivor of gender-based violence. She was sexually assaulted by 10 people, and then she was left for dead, and then she contracted AIDS after that. So, being able to identify some of the issues, it's really, really difficult. Could be cultural, could be emotional, could be a lot of different factors that people don't recognize. And especially for most part of the world, North America is increasingly getting advanced and people are open to talk about mental health and other issues, but for many parts of the world, it doesn't exist. Even if it does exist, it's seldomly spoken about because there is a lot of stigma about mental health, emotional health, and people do not really talk about it more often. So lots of pre-migration is usually when people decide that they are going to leave their home country and go to other country. Stress and anxiety starts building up little by little because they don't know what to expect. They don't know what is going to happen with the new country. They don't have the language. They don't know the culture. They don't understand the rules and regulations and the law. And again, there's a huge conflict between expectations. I'm sorry, something wrong with the internet. Can you guys hear me?
We can hear you now.
Oh, great. I'm sorry, something wrong with the computer here, just went blank. Sorry about that, some technical glitches here. But again, coming back to, so there are lots of issues that clients usually come with, and there is a lot of, expectations and reality. So whenever we receive clients here in Canada or in Lethbridge, there are lots of things they have to compromise. So let's give an example. Even from my home country, when people come from Nepal, the family dynamic completely changes once they come here. Most of the cultural expectations kind of changes. Things happens in a very, very different way. Language given the first, stuff. It's like you don't speak that language. When you do not speak that language, communicating, addressing your issues and concerns becomes really, really difficult. For many different cultural groups, they tend to use nonverbal way of communications rather than using a verbal way of communication. And that kind of also gives a lot of stress to families or people that come here. Rules and regulations and rights. For many parts of the world, like let's say for Nepal, where I come from, you're still a kid unless you're married, and you still tend to live with your parents. But once the family comes to Canada, once you're 18, you are independent, you have the rights to make your own decisions, and then you can do whatever you want to do. That's the concept that we have, or that's how things roll out here. So that gives a lot of stress and anxiety to the parents as well, because there is a little bit of power shift. Now you don't have to do, you expect your kids to come and ask you questions like it used to happen back home, but now it's not going to happen that way. So that stress and anxiety kind of starts building little by little, which really becomes very different, and it gets really ugly when the integration process kind of goes a little further. And again, for coming back with other refugee families that we've seen from Syria and other places, we've seen a lot. I've seen a lot of clients that have actually stood up from their chair when they hear a noise outside, or they have a very difficult way of explaining things because they do not have a proper word or vocabulary to kind of say how they feel. And sometimes language plays a very important role. So let's, for an example, it's very common in my country to say, hey, I'm upset, I want to die. That's very common. And that doesn't mean they're really going to go and kill themselves, but that's only way of showing their frustration. Here, it's completely different. Whenever a person says, hey, I want to die, taken as mental health, and then we refer them to different places that they can get help from. So things are really different here, and it really affects some of the clients that we serve. And again, for integration takes a longer time. Researchers have told that settlement takes only like 3 to 4 years, but integration takes 10 years times, and it's a very lengthy process. And for older folks, people that we see, anyone that's senior, it's very difficult for them to integrate here in the third country, because everything is different. They have lived a very different lifestyle back home, and coming and certainly starting fresh is very difficult. So for an example, if you guys can think, if you guys are right-handed people, you have been using your right hand all your life, you suddenly come to a new place and you're told, not right hand now, start using your left hand. It takes time. And for those age group, it's very difficult for them to kind of start learning new things. So when that happens, they start getting attached to their past culture and tradition more and more. And also tradition plays a very important role when people want to talk about mental health and emotional health and other things. In many parts of the world, many countries, many people don't even want to go to see a doctor because they do not believe in getting medications to heal themselves. They would rather go to a witch doctor who's going to sing songs and play some cards and then heal them. And that is still around many people that come to Canada, or I have clients who still believe in those things, who do not want to go to see a doctor, but instead they would want to see those people who they think can help them spiritually or emotionally. And those are all the things that we've been saying at this point. So yeah, that's my experience working with newcomers, and that's what we've seen. I've always tried to refer my clients to go and speak to counselors in other places, but I'm sure my co-worker at the DAR is going to talk a little bit more about challenges and other things that we face when we help newcomers. Are we good with time?
I believe so, yeah.
Yeah.
All right, thank you, Vic.
Thank you.
As Vic mentioned, we're going to move on to Tadar, who's a settlement practitioner at Lethbridge Family Services since 2015. Prior to that, she worked in a settlement agency in Surrey, BC from 2008 to 2010. During her time in Surrey, she worked as a peer researcher in refugee youth and mental health. A refugee youth and mental health research project with an organization named Assess Alliance Multicultural Help and Community Services in Toronto. In her free time, she likes to cook and spend time with her family. Over to you.
Hi, my name is Tada. Thank you for having me today. For my part of presentation, I would like to talk about challenges that refugees face when dealing with mental health and navigating to access mental health service. We are seeing that a lot of our refugee and immigrant clients who are facing mental health are not accessing to mental health services for these because of these challenges. The first challenges is the understanding of mental health. The way refugees understand mental health is very different from the way Western cultures see mental health. For example, stress to most refugees mean tired. And in Canada, stress can indicate mental health issues. When we discuss about mental health issue with refugee, they directly see a person running down the street without clothes, or a person who cannot take responsibility for themselves. And for those reasons, when we encourage an immigrants to see a counselor for mental health, they feel bad and sometimes offended. And they usually replying that I'm not crazy. Stigma within their community also disencourage immigrants to talk about their mental health issues. They don't want to disclose about their mental health because they don't want it to see as they are weak, lazy, or complaining. And it is very difficult to get an immigrant who is showing mental health symptoms to seek for professional help. And many refugee and immigrants who we work with are not comfortable to express their mental state or discuss about their feeling. And for example, recently we have a client walk away from counseling sessions because the counselor is asking about intimate detail information about her and her husband. It is culturally inappropriate for her, so she just walk away. And most time, immigrants do not realize that they have mental health issues. Many times we hear immigrants express their mental health issue with a physical symptom, such as headache, stomach ache, and when the doctor run all the tests and they conclude that nothing is wrong, and they are getting frustrated by the answer that they get from their doctor. And symptoms like aggressions, anxiety, fear, and forgetfulness, depression are often ignored by immigrants, which we regularly see when we have meeting with them. And often it's not obvious whether it is denied or simply that they don't know. And for those who we have worked with and willing to see a counselor, they have another challenges with language. They cannot communicate directly with the professional counselor, so they have to use interpreter. Sometimes they don't want to use interpreter from the same culture and community background because of the stigma within the community and also the fears of confidentiality issues. And in this small community, everybody know each other. And we also have very limited professional and medically trained interpreter. We have very limited number of interpreters are comfortable to interpret for counseling sessions because some mental health terminology do not exist in some language. It takes a few sentences to explain one word. So I'm from a different culture background. In my language, I couldn't find some of the mental health word. So it will take a few sentences to explain just one word. And we also have, we've been facing that we also have very limited professional counselors that understand and experience working with immigrants and have knowledge about culture background. From our experience, we come across some mental health professionals that are not willing to use interpreter, maybe because of the interpreting issues with the terminology. And most immigrant population we serve here are low income, and most often we need social service support to focus on their mental health and to deal with their mental health. And we find that it is much easier for people with physical health issues to get social support than the one with the mental health issues. People with mental health issues often deny for social and medical support because it is hard for clients to prove how their medical condition affect their daily life, or they can advocate for themselves because they don't understand what is wrong with them. For example, a client wants to see a doctor and she says she's sick, but she cannot say what is wrong with her. The doctor asks if your headache, or it is a headache, or where is this pain? And she says she is okay, but she keeps emphasizing that she is not well. So for that reason, she couldn't get the doctor recommendation to get the social service support. And also navigation to get access to mental health service is not as straightforward as your physical health, like to go to the walk-in or to talk about, to show where it is hurt. And sometimes, most often, immigrant doesn't realize or doesn't know that we have mental health services in the community. And the process to get a treatment for mental health is much longer. And also some case it can be expensive if you need a regular counseling service. For the conclusion, so we know that we need more educations about mental health to be provided to immigrant and refugees, and we need more resources like easy access to professional interpreter. We need more flexible social service it comes to mental health, and we need more social programming support mental health. And we also need culturally appropriate mental health service and more trained professionals who have knowledge and background dealing with refugees and immigrants. Thank you. Thank you. That's all for my presentations.
Okay, thank you for that. I will introduce our last speaker, Deborah, and I'm sorry I don't have a last name written down. She can let us know. Is a development professional with over 9 years of experience working with refugees in Nigeria and Canada. Deborah relocated to Canada in November 2017 and joined Lethbridge Family Services in January of 2018 as a settlement practitioner, providing resettlement and integration services to government-assisted refugees. Her passion stems from providing short and long-term support to displaced populations from developing countries. Deborah is currently studying a master's degree program in human security and peace building at the Royal Roads University in Victoria, BC. Deborah believes that to achieve sustainable peace, basic human insecurities such as shelter, food, health, and education should be met, which is a human right. On this premise, Deborah builds on her skills and expertise to empower vulnerable populations. She also likes kickboxing and watching movies when she has free time. Over to you, Deborah.
Thank you, Dr. Blair. Thank you for having me today. Briefly, I just want to talk about a case study of one of our clients during COVID-19, how she responded to this situation, and what are the mental health signs that it showed during this period. To start with, I will just give a brief background on the family composition and the personal composition of the clients that I will be using as a case study. Although some of the composition have been modified for privacy reasons, so my clients will not be able to be identified. So I just modified it slightly. It's still very close to who the client is. So she's a single parent with 6 children, 3 boys, 3 girls, have a child with disability. Some of the children have severe health issues or regular medical medication and regular visit to the doctor. For her personal composition, she has low level of English. She have health issues herself. She's of course a low income earner. But despite all this, she's strong and resilient. She tries to pull through, support the children, and then try to be there for them. She was dealing with all these pre-COVID. So at the emergence of COVID-19, she was disturbed because she had little understanding of what COVID really is. She doesn't understand. She just had the mindset that she could die or a family member could die, and that really freaked her out. So after several interventions, several ways working with her, it was difficult to work with her virtually as well, but we had to find creative ways to work with her. So despite all that, she had improved understanding of the situation, but she did not have the situation under control at all. She doesn't have information about COVID-19 updates, so she just hear information from outside, wherever she can pick from, whether it is the fact or not. She just work with that, and that also aggravated level of fear. At some point, she had to lock herself indoor. She locked herself up. She locked her children up. She doesn't want anyone to go out or anybody to come into their house because she believes that once she has that contact, she could lose any of the children or she herself could die. So she's displayed a high sense of stress and anxiety because of the sudden changes. There were regular visits to the family doctor, like almost every day. Within a day, she can go 3 times just saying she's about to die. I think she has COVID. I think I have COVID. I think I'm sick. I think my children is sick. So she just keep freaking out at every slightest thing, frequent 911 calls. 911 visited her like 3 times in one day. Once they come and they're like, okay, you are okay, just stay indoor, and they leave. Just shortly after then, she feels she's coughing or she feels something is wrong, then she places a call to 911 again. Several visits to emergency room, not only her, even the children will just go there and say, mommy is dying. And several times we've tried to intervene, whereas she's okay. Probably she just had headache, or she just have limited symptoms of any other illness. Sometimes we book appointment to the doctor and doctor just send her back home saying everything is okay. She should just go and rest. But she was just freaking out all through the process. Another sign that she displayed was low energy. Despite all the things that she's dealing with, the health issues of the children, her own health issues, they are dealing with the child with disability, trying to provide support to the family as a single parent. She had energy to pull through, but this time around, she had low energy. You will see that disinterest in many things, in activities. Sometimes she's just there with you without being there. You know, she's physically present, but her mind is not with you. And she overly dressed during during COVID-19, even till now. She covers every part of her body. If she has to go out and just leave only her eyes out, she covered every place, just tight clothes around all these areas. So she's not dealing with the situation well at all. So some of the things that she displayed all those time was like she was very, very isolated. She removed herself from the community, removed herself from friends, just always locked herself indoor. So she had less social support. So we had to work with her sometimes over the phone. Sometimes we stay outside her door, talk over her window. She just lives in constant fear. Before COVID, she had support, traditional support, like from cultural group, from a community. But during this time, because of lockdown, no friends visits, no time to chat with friends, she's just isolated, and that really aggravated fear. Every time you talk to her, it's always one problem or the other, one fear or the other that she's actually dealing with. So some of the things that also fueled the situation, whereas she had so many mental health challenges this year, was loss of employment. I wouldn't say loss of employment directly, because she just stopped going to work out of fear. So because she believes that if she go to work, she will be able to meet with people. She had to use the public transportation, and then anything could happen to her and the kids. So she stopped going to work. She was working part-time. She was on government support. So she now only relied on the government support. So her income was reduced. Then she had to like buy all the PPE kits. She had to buy soap, buy all those things just to ensure that she has enough things to keep the family safe. So that reduced income increased anxiety of financial situation. So she keep worrying about where she will get money, how she's going to get money to do all these things. She doesn't have enough money as she used to. So she asks a lot of questions about finances. Sometimes if you're talking about something totally different, she will just hear, oh, what about how will I pay for this? How will I pay for my bills? And all that. And then she even stopped going to pay for bills at the bank because she cannot go there. She rather said, I will face the consequences rather than going to the bank to pay my bills. So she was really isolated and living in strong fear. So we tried to set her up with some financial support program and some social support program just to get by during this period, and then to build her resilience and become empowered and take charge of the situation. But however, she still finds difficulty dealing with all those things. As long as COVID still exists, the fear increases and becomes stronger. So when she's on income support, normally she does a monthly reporting regularly, but now she forgets about monthly reporting. Her level of forgetfulness increased severely. She forget to report. Then because she didn't report, she didn't get money. Then she began to get scared because then she doesn't have money. So we had to like track the case management group set up for her so that we could track all those details and help her missing pieces so that we don't allow anything to fall down the crack and then aggravate or as anxiety or anything. So even doctor's appointments, except it is related to COVID or someone is sick, if there's any other thing, especially any other thing, maybe dental or anything, she forgets almost every other thing. The only consultation now is on COVID-19. So for health practitioners, before she could easily book appointments if she wants to see a doctor walking there, but now she can't walk in there. So she's also scared that even if she's sick or anything is happening to her, she can get a doctor easily because she can't go to the clinic as usual to book an appointment. She also doesn't want to come to our office because she's going to meet people in the office. So all those things all contributed to her fear. And then sometimes even if we're talking with her or she's talking with someone, poor concentration, even in medical appointments, she doesn't even, on this, because the fear is there, all she's thinking is COVID-19, so she doesn't even listen or hear what the doctor is saying. Then after the appointment, she's always freaking out, saying, oh, what happened? What happened to my son? Why did I go there? What did they say? So we have to like be in appointment with her so that whenever that comes, we can explain what the doctor said, why the doctor said it. It's not a big deal. And just try to make sure she manages what is going on with her. She also have issues with going to grocery stores, so there was no food in the house. We had to start making orders, delivering food for her, and also community support, all like cultural groups who were dropping food at her door so that they could also have something to eat. And regarding school, she has, I said earlier, she had 6 children below 18 years old, so she had to keep all of them in the house. They can go to school. She doesn't want them to go to school. And at the same time, she's not literate enough to be able to support them with to use the computer. So they just stopped inside the house with our YSS team, that is the youth settlements practitioners. They had to work with her, try to encourage you to help the children set up. Then she started getting scared of, oh, my children's future is ruined, they can't go to school, and I can't help them at home. So we had to like help her with that. So it's like every phase of her life was fear, anxiety, and she's just traumatized all through the period. Till now, she's getting better with close support that we're giving to her, but she's still dealing with it in a very, very bad situation. So sometimes there was a day that one of the sons had to go to emergency to call. And when the guy came home, he took the guy immediately. He didn't allow the guy to touch anything, dragged the guy into the washroom, use soap and sponge and scrub all his body because he believes that the guy might have brought in COVID to them. It's good to wash your hands to clean up, but the way she does it is out of fear, and then she just keep the boy there and just watch it. Maybe something will happen to him. And if once he called, you'll be like, oh, will this person die now? You went out of the house. Or like, no, nobody's dying. We tried as much as possible to explain the whole situation to her. But so one thing that we see is that sometimes if there's a culturally appropriate information, that's people that you could hear directly from maybe Alberta Health Services, so that they could see that this is the situation. So it's not someone narrating the story to them like, okay, I understand this is what AHS is saying, and this is the situation. If they can get it directly from source, that would really, really help. And also the major thing that I see in this client is anxiety, fear, and trauma. So those are the major symptoms that she displayed. Accessing public health system information and sending updates in multiple language will be a way to go, so that immigrants that has low level of English can also have first-hand information on what is going on relating to COVID. So thank you. That's just a case study of one of our clients during COVID-19. Thank you for listening.
Thank you, Deborah. I believe we have some time for questions, do we, Stasha?
Yeah, we have a little time for questions.
Okay, who should I turn it over to? Is Lindsay monitoring that, or?
Lindsay?
You bet, I can monitor that. There was no questions put into the chat box, but does anybody have any questions they just want to ask or put in the chat box at this time? That was my wait till 8. I've got a few questions. I was kind of wondering from a provider perspective. So my role is I work at Alberta Healthy Living Program. I work in the diabetes program. So I would see patients one-on-one. And I know that in our program, we've had a few situations, I guess, where we've maybe thought there might be some mental health problems, but we weren't really sure how to approach it with the client, where we would send them. Do you guys have any tips, practical tips for clinicians about, if you're kind of thinking this might be an issue, what would be a safe way to bring it up with the client? Anything like that?
So I would just jump in. Usually, if you can encourage them to talk to their doctor about it, it might work. But from our experience, it is harder to bring up it is harder to bring it up. That's the issues because of the understanding of mental health is very, very different.
Yeah, we had the experience, well, I didn't, but a colleague did, where she had a fellow in, and I don't know what country he is from, maybe Serbia, but she had kind of asked him, would you like to see a counselor? It sounds like you've got some things you need to talk through, and it did not go well. He thought she was calling him crazy. The interpreter on the language line was like, oh, no, this is not good in his culture. So it was quite an experience. So definitely we're learning things like that, maybe we can't use the same language that we would use.
Yeah, definitely vocabulary kind of works huge. So some of the words, so some of the phrases that we use to describe mental health in this part of the world, it doesn't exist back home for lots of folks and lots of clients that we serve. So I think choosing the right word and using the right phrases to educate them about mental health would kind of serve the purpose. But again, I think it's stigma. Lots of people, when you talk about mental health or emotional issues, there is a huge stigma about people calling them crazy. They would not even, sometimes they would not even want to use interpreters from their own community, because then they will be like, outcasted from the community, or they will think they're crazy or something. So it's a very sensitive issue. And I think many clients would like to take time to understand more about it and then eventually talk about it. So I think it's all about choosing the right vocabulary and being a little time sensitive when addressing mental health, as far as my experience goes with working with some of the clients in the past.
Vic, do you have any tips on specific words or phrases that you would suggest?
So for my clients, so whenever I talk about mental health or emotional health, I usually give an example to my clients here. It's like, if you have an eye issue, I send you to an eye doctor. If you have a dental issues, I send you to a dentist. Same way, if you have any problems with your feelings, you need someone that could help you listen to your feelings, we send you to counselor. They may not prescribe you medication to heal, but they will sit down and listen to you and help you ease up that burden in your chest. Some people easily comprehend that. And for some clients, it takes a longer time to kind of comprehend what we're talking about, because again, it doesn't exist back home. For many of my clients, it's very, very new. So it definitely will take time. So that's the approach I've been giving to my clients.
Thank you, that's helpful.
So to add to that, some of the phrases I use, I try to stay away from the word mental. So because that is the trigger. So if they are showing any sign, or they are showing anything, or like, oh, it looks like you're worried about this thing, it looks like you're disturbed, do you want to talk to someone? If you talk to me, I can listen, but there are professionals that when you talk to them, they know what to say, they know what to tell you, they know how to direct you. You want to, I don't even use the word counselor most times. I think they already know what counselor means. So I just use, you want to talk to a professional in our office, that's their own, they know how to deal with you in this kind of thing. They know what to tell you. I don't know what to tell you. So that's where I just go around it and like, okay, yeah, I want to talk to someone. So, but that didn't really work out well, because sometimes when they now go there, then when they go to see someone and the someone turns out to be a counselor and it's on mental health issues, it's like sometimes they just don't go ahead with the appointment. So that's why recently we're thinking of, look, probably the first appointment should be like an information session, because when you tell them, do you want to talk to someone, then maybe when they now get there, to just be like information session, educating them on what mental health is. Then asking after that, do you want to proceed? Because because the first impression they had when I was like, do you want to talk to someone about this problem? Do you want to? By the time they get there and they are signing the consent, they realize it is mental health, and then that brings the trigger. So those are the kind of words we frame around it, and just to get them to see a counselor.
Yeah, I can definitely see a challenge because often the place you'd be going would say mental health on the door, right? Like, and so that could be a bit of a barrier if that's a taboo term for sure.
I have a quick question for.
Oh, sorry.
Oh, I just wanted to ask John a quick question. How much of a correlation is there between trauma and other conditions such as ADHD, oppositional defiant disorder, things like that? Obviously, depression and anxiety can certainly go along with it, but what about some of those other more complex mental health disorders?
That's a really good question. I don't have the answer to that. I'm not sure. What I can say though is that if a person has other conditions, and let's include lots of those, it could be a chronic health concern, like a physical chronic health concern. It could be, you mentioned depression, anxiety, could be something like that, and they experience traumatic events on top of that, then it seems reasonable to me that there's the likelihood of an influence of one thing influencing the other, making it more challenging, or making other symptoms worse. But I can't speak specifically to that. I am a registered social worker, but I am not. I'm not a psychologist, and so I can't be any more specific than that, except to say that again, that if people are experiencing traumatic events, that making sure that they have the opportunity to reach out to qualified supports is the most important thing, and help seeking, right? And I'm hearing, my teammates from the immigrant services part of Lethbridge Family Services talk about how important it is to have a service that reaches back, to have somebody that is willing to have conversations with people that are maybe really challenging, and maybe take a sort of an educational piece at the beginning too. So yeah, I can't be any more specific than that though, doctor. Sorry.
Okay, thanks.
I just have a question. Working in the fields of recreation and sports and arts and culture, so we have doctors in the community that prescribe people to get active through a program called Prescription to Get Active, that reinforces to individuals that come in with certain medical issues, like physical medical issues, that being active may be helpful to their overall physical health long term. But we also know that recreation and sports and arts and culture are so important for mental well-being and social inclusion and that type of thing. And the city does have a subsidy program that helps deal with the financial barriers to participating in those kinds of activities. So how would we work with, I mean, I already do work very closely, like with immigrant services, for example. They know about the program and utilize it often, but now I'm starting to wonder, maybe there's a gap within the counseling community that doesn't know about this program. And do you think that there is an appetite or need to help make these programs accessible to these individuals, or is this, they're not ready for that yet? That's, I'm assuming a higher like I understand, like, you know, with depression, you may be unmotivated to go, so you might have that barrier and that type of thing. But with the trauma, do you think individuals would want to be like going swimming or going to the gym or taking an art class and having working with us to make sure that the barriers are identified and dealt with?
I think that's a great idea. I think if we can frame it like Vic was talking about, you know, if you have eye problems, we send you to an eye doctor. If you say, well, one of the treatments for what you're feeling is more activity, then you know, if we can frame it that way, we probably have a better chance of helping people get active. But it has to be part of the overall treatment program, because it, like you said, if people aren't motivated to go somewhere, they're not gonna,
Yeah.
you know, they're gonna have a hard time being active. So it would be part of it. Right now, it's a problem because a lot of opportunities for activity are very restricted, and so I wouldn't want to try and start something new right now.
Yeah.
But it would certainly be something to look at when things settle down.
Yeah.
Well, and I really do like what you said about, is it possible that there are people working in the helping professions as counselors or other supports that aren't aware of the city program and subsidy, or maybe aren't as aware. I think most of them would be generally aware of the complementary part of, hey, taking care of your physical self and your emotional self, and it's not as strictly compartmentalized as it might seem, that taking really good care of your physical self or your psychological or emotional self influences the other parts of that too. And so maybe this is the opportunity for educating other service providers about that program and how to access it, and then, you know, once things are opening up again, to be able to refer clients. Yeah.
Mm-hmm.
If I could just add something, we were at a conference last week, and one of the things that came up for Another Lip was that they, in their mental health programs, they had peer support. So there was some support from different in different cultures. So I'm wondering if Lori, just what you're saying about, I know not in COVID, but if that is a model that would work, so that they're just not going off by themselves, that maybe there's a cultural support, peer support component to that. Just a thought.
Yeah, I mean, I'd be willing to look at anything and everything, because I think, you know, I mean, the most important thing is that people are utilizing that program, and the benefits, of course, are very, like, all so holistic, right? The social and yeah, the meeting new friends and feeling like you're part of the community and feeling welcomed. And I also see it in the bigger picture as also a way to educate people who might be racist, you know, to seeing and once you start seeing and meeting individuals at the gym that are from around the world and start talking to them, maybe it would challenge some of the beliefs that people have. So yeah, we should definitely talk, Laura, long-term about how we could do that to incorporate this into more people's their healing journeys.
Yes, I would love that.
Maybe that can be a topic for one of our future webinars.
There we go.
We need to wrap things up here. We don't currently have any webinars booked, but we will be presenting more in 2021. So we will just to keep an eye out for notices about upcoming webinars, and we will pass the word around when we have one set up. I'd like to thank our speakers again, John, Vic, Tadar, and Deborah, for sharing your experiences with us. And I'd like to thank everybody for participating. Is there anything else? Oh, this webinar is recorded and will be available on the LIP website shortly, I believe.
Mm-hmm. I will
And
also,
so I will also post
the cultural safety
Infographic.
infographic. Yes, thank you.
Perfect.
And thank you to
All right.
Dr. Bly
Thank you
as
again
well.
for your,
Sorry.
thanks for your
Thank you, Dr.
participation,
Bly.
everyone. You're welcome. All right. Take care, everybody. Stay safe.
Thank
Take
you.
care.
Thank you.